always a pleasure to participate in our annual conference among this distinguished gathering. We're talking today about plasmapheresis. Well, this is the National Institute of Urology and Nephrology. Our agenda will be definition, indications, mechanism of action, replacement, solution, how to choose a plasma filter, complications and precautions, and general orders. Plasmapheresis, total plasma exchange, or TPE, it comes from the Greek word apheresis, that's say taking away. It is the procedure in which the patient's plasma is separated and removed from the whole blood. The first known attempt of doing plasmapheresis with the concept that we use nowadays was in 1914, yet the first plasmapheresis sessions attempt successfully were in the 50s of the last century. Again, there was some historical trials of what we call taking out blood, like in cupping or venesection or hijama in Arabic, and they all has the same concept, is to take out the bad blood and get rid of it. The removal of plasma is replaced by 1-to-1 ratio usually with a replacement solution. The general indications for plasmapheresis, I will stress on some of them. Example, hyperviscosity syndrome, acute demyelinating polyneuropathy or Guillain-Barré syndrome, homozygous familial hypercholesterolemia, selective adsorption, myasthenia gravis crisis, Repsom's disease, cutaneous lymphoma, photopheresis, HIV-related syndromes, polyneuropathy, hyperviscosity, TTP, coagulation factor inhibitors, ABO incompatible marrow transplant, bullous pemphigoid, and immune thrombocytopenia, staph protein A adsorption, and finally hemolytic disease of the newborn. The American Society for Apheresis in 2016 set some indications for therapeutic apheresis and cytopheresis procedures. As we said, acute disseminating encephalomyelitis, when it's steroid refractory, acute inflammatory demyelinating polyradiculopathy, Guillain-Barré syndrome, whether as a primary treatment or after intravenous immune globulin administration, acute liver failure, age-related macular degeneration, dry or what they call rheopheresis, amyloidosis, systemic amyloidosis for beta-2 microglobulin removal by column, and TPE, ANCA-associated rapidly progressive GN granulomatosis with polyangiitis, example Wagner's syndrome, or microscopic polyangiitis, whether it was dialysis dependent or independent, or in the case of diffuse alveolar hemorrhage. In kidney transplantation, the indications, we have before transplantations for treatment of renal disease, for prophylaxis of recurrence of original kidney disease, example in FSGS, and for desensitization, PRA or ABO incompatible transplantation. After renal transplantation, for non-rejection regions like recurrent of FSGS, anti-GBM disease, hemolytic uremic syndrome, or in antibody-mediated rejection, though it is doubtful nowadays. Plasmapheresis for the treatment of kidney disease, if we look at this graph, you'll see like that TTP and HOS represents almost 60% of the indications for the usage of plasmapheresis in nephrology, transplantation around 12%, ANCA, cryoglobulinemia, FSGS goes around 7%, and Goodpasture syndrome, 5% of the indications for usage in nephrology. The mechanism of action, the possible mechanisms of action for therapeutic plasma exchange, whether removal of abnormal circulating factors, example antibody, as what we do in anti-GPM disease, myasthenia gravis, Guillain-Barré syndrome, monoclonal protein, Waldenstrom, macroglobulinemia or myeloma protein, circulating immune complexes, cryoglobulinemia, SLE, alloantibody, RH, alloimmunization in pregnancy, toxic factors like TTP, HUS, and FSGS, or by replenishment of specific plasma factors as what we have in thrombotic, thrombocytopenic purpura, and other effects on immune system, improvement in the function of reticuloendothelial system, removal of inflammatory mediators, cytokines, complement, shift in antibody to antigen to more soluble forms of immune complexes, and stimulation of lymphocyte clones to enhance cytotoxic therapy. These are examples of the pathologic substances removed by therapeutic apheresis, immunoglobulins as in hyperviscosity in Waldenström, multiple myeloma, autoantibodies, myasthenia, anti-GPM, systemic lupus, systemic vasculitis, factor VIII inhibitors, TTP, lipoproteins in hypercholesterolemia, leukocytes in hyperleukemic leukostasis, platelets in severe thrombocytosis, abnormal red cells in sickle cell disease, circulating immune complexes in glomerulonephritis, SLE, or vasculitis, and protein-bound substances and toxins, thyroid storm or Amanita phalloides toxins. As we all know, plasma constitutes the soluble form of blood after taking out the cellular components of blood. Plasma is basically consisted of water in around 90%, 6 to 7% proteins, and around 3% other substances as fats, carbohydrates, namely glucose, electrolytes, gases, and chemical messengers. This is the distribution volume or the molecular weight of the substances, the different substances in plasma. As you can see that albumin is almost 69,000 Daltons, IgG 180,000, IgA 150,000, IgM 900,000, and cholesterol or beta lipoprotein, low density lipoprotein, 1,300,000 Dalton. So they are really big molecules. Here we can see the effect of different modalities of, we can call it dialysis, or how we reduce these substances from the blood in relation to the different molecular weight. The small molecules, example, the BUN and creatinine, they are removed by hemodialysis with diffusion clearance. Bigger molecules like vitamin B12 or beta-2 macroglobulins or kappa light chains, which are the middle molecules, are removed only by hemofiltration by convective clearance. Hemodialysis is not effective in these methods. Again, larger molecules, very large molecules, like the albumin, IgG, IgM, etc., they are not removed except by the TPE or therapeutic plasma exchange. TPE is done through two modalities, whether centrifugation technique or plasma filtration technique. The concept of both, in centrifugation technique, the whole blood is taken into a spinning centrifuge bowl, and then according to the different weights of the different constituents by gravity, you can separate red blood cells, white blood cells, platelets, plasma, etc., and then plasma is taken to the collecting bag and replaced by a new albumin or plasma. While in plasma filtration technique, blood is taken from the patient from the arterial side, as what we do in dialysis, and then through the plasma filter with an ultrafiltration pressure sensors, and using the pressure and the pores, the bigger pores of these filters, the plasma is separated to the effluent bags, and the remaining blood returns back to the patient with the replacement solution, again, whether plasma or albumin. Here we can see the beginning of the true modern plasmapheresis in the last century. In 1973 in Glasgow, in UCSD 1982, and the membrane plasma filtration in 1983. Again, these were the first attempts of what we have nowadays. These are the machines. We have the membrane machine and the centrifuge machine. Some examples of the mechanism of action, as we said, in filtration by single filtration technique, by pore size and charge differentiate, filtrate plasma compounds from blood, as we can see, and centrifugation technique by gravity and density differentiate plasma compounds, platelets, leukocytes, stem cells, and erythrocytes. Again, this is the diagram of what we described. Double filtration easily is that when you use the plasma filter, you filtrate the desired substances to be filtrated, the bigger one, and some of the small molecules that you don't want to lose. Then these filtered substances, again, are run through another membrane with smaller pores where the big molecules are entrapped and the smaller molecules are returned back to the patient, so you are not depriving the patient from the important factors that you don't want to get rid of. This is the Rio filter. It's the same idea for acute macular degeneration. It's the same with a plasma separator and Rio filter, and it works with the same double filtration theory. This is an important figure, actually. It shows the direct relationship between transmembrane pressure and filtration rate when plasmapheresis is performed with hemodialysis equipment. You can see that here, in contrast to the usual practice, filtration rate is graphed as the independent variable, and transmembrane pressure is the dependent variable. The maximum filtration rate is achieved at relatively low TMP pressure, approximately 40 millimeter mercury. Comparing centrifugation and plasma filtration, the advantages of centrifugation: it's more efficient removal of all plasma components, can be adopted for cytopheresis, and no need for cardiovascular, central vascular catheter, because it only requires 40 to 50 milliliter per minute flow, while the membrane plasma separation, there's no loss of cellular elements, no requirements for citrate, and can be adopted for cascade filtration, while the disadvantages for centrifugation, it is the loss of cellular elements of blood, use of citrate, anticoagulation, hypocalcemia is very common, arrhythmia again, and hypotension are prominent, and it is a bit expensive. While in membrane plasma separation, central vein catheters are required because it requires higher blood flow, not less than 100 to 150 milliliter per minute, and it is limited to plasmapheresis. The relationship between plasma volume removed and the concentration of substances: at 0.5 of plasma volume, you with volume exchanges of around 1400 milliliter, you remove 39%. At 1 plasma volume, around 63%, 1.5 is 78%, and 2 is 86%, etc. And for this reason, usually 1 at most 2 plasma volume equivalents are exchanged during 1 plasmapheresis sessions, because at these levels you can take from 60 something to almost 85% of the desired removal. This is the comparison, or the immune absorption versus plasmapheresis. Example, antibody reduction therapy, immune absorption. Advantages of immune absorption is it is highly selective for immune absorption versus plasmapheresis. High selectivity facilitates therapy schemes involving more than 1 treatment on each consecutive day, since only small amounts of essential plasma components such as albumin are removed. In the case of other extracorporeal procedures, such as plasma exchange, this is difficult to achieve. This is the antibody reduction therapy technique by immune absorption. I will skip it. Reaccumulation is important when we design the session or plasmapheresis for the patient. We have to know that reaccumulation rate is high in the first 3 days, and then it goes down steadily. And that's why in most protocols, the first 3 sessions usually are performed daily, and then you can go for every other day protocol in most of the cases. Replacement solution, we replace whether by albumin or fresh frozen plasma. Advantages of albumin: there is no risk of hepatitis, stored room temperature, allergic reactions are rare, no ABO matching, depletes inflammation mediators, while the disadvantages is that it is expensive, no coagulation factors, and no immunoglobulins. In fresh frozen plasma, the advantages are that there's coagulation factors, immunoglobulins, complement. The disadvantages is the risk of hepatitis, HIV, allergic reactions, hemolytic reactions, must be warmed, and ABO matching. Fresh frozen plasma, it has only one specific indication in practice, which is TTP or HUS, and something like pre-existing defect in hemostasis and risk of choline esterase depletion, but we need to stress that TTP and HUS in the practice is the only one, because unfortunately we see in many cases that in some centers they give fresh frozen plasma for other indications which are not correct, just because for the sake of the expenses. So you are giving the patient an unnecessary hazard with no benefit. How to choose a plasma filter? It has to have better sieving coefficient, better hemocompatibility with less hemolysis, less platelet loss, more biocompatible surfaces, and less TMP values. You can see that the sieving coefficient in plasma filter is much, much higher in membrane for plasma filters than that for dialysis, for all the components, even the bigger components like the IgG and IgM, albumin, etc. The surface area of the membrane does not really give that big differences in clearance. It's only the difference between 0.6 square meter or 0.3. Usually it only varies in the amount of blood. So when you have a smaller patient or a younger patient or a little child, you can use the smaller one and the bigger one for bigger adults. The complications of plasmapheresis: some related to vascular access, hematoma, etc., related to the procedure, hypotension, or bleeding or edema formation due to decreased intravascular oncotic pressure, loss of cellular elements, ethylene oxide associated hypersensitivity, and related to anticoagulation, bleeding, hypocalcemic symptoms, hypotension, arrhythmia, etc. Precautions for hypocalcemia: prophylactic infusion of 10% calcium, hemorrhage 2 units of FFB, thrombocytopenia, consider membrane plasma separation, consider continuous flow separation, infusion of intravenous immunoglobulin for infection, post-apheresis, ensure potassium concentration of 4 millimole in the replacement solution, and change membrane, or consider centrifugal method of plasma separation. Hypothermia: you have to warm your patient. Sensitivity to replacement: consider a diagnostic evaluation of anti-IgA antibody, anti-ethylene oxide, etc., and pre-medication regimen for sensitized individuals: prednisolone, diphenhydramine, ephedrine, etc. General orders: calculate the plasma volume, measure the plasmapheresis when feasible, measure the plasma level of the substance to be removed, space treatment approximately 24 hours. For heparin anticoagulation, you have to use heparin cautiously with 50 units per kg initially, then 1,000 units per hour. Target ACT is around 145. And for citrate anticoagulation, use ACDA at 1 to 15 to 1 to 25 dilution. Use calcium infusion if necessary. Cardiac monitoring. Administer scheduled medications only at the session, and catheter.
Dear doctor, your time is up.
دقيقتين ولا صعب؟ ممكن دقيقتين؟
1 minute.
اوكي. طب دقيقتين يعني. دقيقتين. خليهم 2. ماشي، شكرا. These are different regimens for plasma exchange. The duration of treatment in HUS, 7 for 10 days, or until platelet count goes to 80 to 100,000. Replacement fluid by fresh frozen plasma, as we said, only for TTP. Addition of replacement fluid in the case of anti-glomerular basement membrane antibody. Occasionally, you add calcium gluconate and potassium chloride. In immunosuppression, you use prednisolone and cyclophosphamide in type 2 cases of cryoglobulinemia, and variations in other modalities you can use, especially in anti-GPM, fresh frozen plasma for 8 to 8 milliliter per kg as part of exchange volume if hemorrhage risk is available. This is efficacy of rituximab and the plasmapheresis in adult patients with auto-antibody-associated hemolytic disease.
Dear doctor, your time is up.
Thank you.